Hey everyone, good afternoon. I hope everybody's doing well. It's good to see everybody. Want to welcome you, Ellen Hahn here. I think I see everybody knows who I am at this point, everybody on so far. Good to see everyone today. And I'm the director of UK Cares, as you know, and want to welcome you to our regular environmental health sciences seminar, or we lovingly call this a Zoominar because we can invite people from all over the world. And it happens to be that our speaker, Sue-Ann Bell, is actually in Barcelona today. So this is truly a global community here. And so I am so excited to welcome Sue-Ann. I've been wanting to hear about her work for a very long time. Sue-Ann Bell is a nursing colleague of mine, although I haven't met her until today, but she is faculty at the University of Michigan School of Nursing. Many of you know that Michigan has a sister center to ours, the M-Lead Center. And so she does work with the community engagement person there, Amy Schultz. But she works at the intersection of research, policy, and practice to address the health needs of disasters and public health emergencies. Dr. Bell's research focuses primarily on health and well-being of aging populations in the context of disaster. And she is interested in those long-term health impacts on health, chronic health conditions. She does serve on FEMA's agency's National Advisory Council and HHS's Council on Seniors and Disasters. She is an active in disaster response as a clinician, as a nurse practitioner through HHS's National Disaster Medical System. And she's, thank you for your service, has done recent deployments, including COVID-19 pandemic response, as well as Hurricane Maria in Puerto Rico. And so we're very excited to hear about your research, and I'll turn it over to Sue-Ann. Thank you.
Well, thank you so much for having me. Let me share my screen and see if my slides are working. They do. Today I'm going to be talking about some of my research that is policy engaged to serve my ultimate goal, which is building a better disaster response, and particularly for older adults. I have no disclosures and have funding support from the National Institute on Aging. And this talk is organized into three main parts, where the first part is about understanding the effects of extreme weather events on the health of individuals and communities. I'll spend the second part of the talk talking about some of my specific research and a little bit about some of my on-the-ground emergency response. And then the third part of this talk will be about some of what I see as the urgent policy and scientific needs about aging and disasters through the disaster management cycle of mitigation, preparedness, response, and recovery, which I'll also talk about in that section. Okay. So as Dr. Hahn mentioned, I'm a nurse practitioner and active in disaster response for probably more than 15 years. Then the picture on my left is me heading to the Hurricane Irma response. The bluish arrow is me in a C-17 where we landed using night vision after the airport was closed in Orlando, and I spent a couple of weeks there supporting overwhelmed emergency departments. The picture on my right is after Hurricane Maria, where I spent over the course of a couple of months, around 6 months, in various parts of Puerto Rico, supporting some of the immediate health response after Hurricane Maria. I also spent a lot of time during COVID responding to various COVID challenges. And in this picture on my right is I'm in the state of Maryland early in the pandemic, doing voluntary nursing home infection control assessments and PPE training. And I didn't have a good picture to share, but I also spent, I think it was March of 2021 in Hazard, Kentucky, supporting a monoclonal antibody clinic. So spent about 2 weeks there and got to know the community and the staff at Hazard Appalachian Regional Medical Center quite well during my time there. So as I started to talk about, the focus of my work is about building a better disaster response, and specifically one that leads to a more resilient health system from the effects of climate change, particularly around extreme weather events. And so I think of, in this infographic from the World Health Organization about their climate resilience strategy, I think of myself as my work situated in the black circle of emergency preparedness and management and health and climate research. But I always start every talk by giving what I consider to be the definition of a disaster. This is coming from the International Federation of the Red Cross and Red Crescent. But the equation in the center is how I, think about disasters and organize my thinking and my research around disasters. So when a vulnerability meets a hazard, exceeds capacity, that's what a disaster is. And we'll talk a bit more about this throughout the talk. I also, you'll never find me saying the word natural disaster. I don't think of disasters as natural. And actually, the United Nations Disaster Risk Reduction agency has specifically come out with a campaign saying, don't call disasters natural. It's the hazard itself that's natural. But the way that the hazard impacts on infrastructure and communities, that's largely human-made, and we can do a lot better in mitigating some of these effects and recovering from some of these effects. So if you think about this picture on my left of the flooded Amazon River basin, which has very, very little infrastructure and regular seasonal flooding, to the picture on my right, which is the city of New Orleans after Hurricane Katrina, a city that's built in a low-lying area that had, some challenges with their infrastructure, particularly around the levees that failed, leading to the flooding of the city. We know that there was a lot to do with Hurricane Katrina that was preventable if we had thought about what some of those mitigation and preparedness activities are. We also saw some of those same challenges during COVID, where in this picture that comes from the New York Post, I think, of healthcare providers who did not have PPE early in the pandemic, and resorted to wearing, garbage bags in lieu of gowns that they couldn't reach or couldn't access. We know that much of the spread of COVID-19 was preventable with appropriate pandemic planning in place. Another central aspect to my work and in thinking about disasters is that we know that disasters disproportionately affect communities and groups that are already structurally marginalized. This is a picture of a nurse named Mary Jo D'Amico, who's caring for some of the very last patients to be evacuated out of Memorial Hospital after Hurricane Katrina. These were the patients that were in nursing homes, or the nursing home long-term rehab part of the hospital. Many of these people had do not resuscitate orders and were the very last to be evacuated. The staff was left alone for more than 5 days, waiting for communications to come back online and a better understanding of what evacuation would be for this patient, and led to a number of very challenging outcomes and ethical concerns that happened during those 5 days with very little communication. Some of you have heard of the book, Pulitzer Prize winning book, 5 Days of Memorial by the author Sherry Fink. If you haven't read it and are interested in some of the ethical dilemmas around disaster management, I would recommend it. So thinking about some of those, how disasters disproportionately affect communities. I know in Kentucky, July of 2022, there was extreme rainfall, more than 8 to 10 inches in some areas. Estimates put around somewhere between, in the area of 43, 45 people lost their lives in this disaster. Certainly a community where this this extreme weather disproportionately affected disproportionately affected the residents. Some of the reports in thinking about recovery were that only around 4% of those applying for housing recovery had flood insurance, and that the maximum FEMA grant per household was less than $4,000. So for those communities or people living who owned their homes, very few had flood insurance. So, making response or recovery quite a challenge. And even then, the amount of assistance, disaster recovery assistance that almost anyone was eligible to receive was, fell far short of what anybody can conceive of as rebuilding or repairing their homes. We also know that we're an aging nation, and in the next 10 years, we're expected for the first time in the United States, older adults are going to outnumber children. We're facing the aging baby boomers and some, fairly substantial challenges in meeting healthcare needs for older adults on a daily basis, much less during a disaster event or during extreme weather. So when I think about that definition of a disaster, again, vulnerability plus a hazard exceeds capacity, that's what makes a disaster. But for older adults, there's a number of different challenges that come with aging, not necessarily for all older adults, but for many older adults that make them have these unique challenges during a disaster that we can do work on now to better address. Some of those are chronic and comorbid disease. We know that around 80% of older adults have at least one chronic health condition. Many older adults live in social isolation, may not have regular family, friend, neighbor contact, might not have, internet access or familiarity with navigating parts of the internet to provide some of that social support. Some older adults are facing challenges with cognitive impairment, particularly around dementia. Frailty and mobility is a more common challenge that comes with aging. And finally, economics and living on a fixed income, all challenges common with aging. So I wanted to shift and talk about some of my research that looks to address some of those key factors that I think about as challenges for older adults during disasters, and specifically challenges that we can work to address. So some of my early work looked at hospitalizations after disasters, with the idea of trying to understand what is putting older adults in the hospital after a disaster. What's causing older adults to use more healthcare than they normally would after a disaster? So this early paper, we looked at the 2011 Southeast Superstorm, which was a series of, which was a severe thunderstorm that passed over a large portion of the Southeast and spawned something like 300 tornadoes, led to a number of fatalities. So we used this as our setting and used the MedPAR files from Medicare data, from the Centers for Medicare and Medicaid Services. We used an analytic method called a self-controlled case series, which is unique in that individuals who are participants in the study serve as their own controls. So we're comparing individuals to themselves, so making confounders controlled for within the modeling. And the key focus of a self-controlled case series is that the analysis is based on when an event happened. Self-controlled case series have been used commonly in studying adverse reactions from immunizations, for example. So we looked at the 30 days after the Southeast superstorm, and we compared that to the rest of the calendar year on either side. So we looked at the period before the superstorm, and we looked at the period after, and had this 30-day period where we were interested in if there were excess hospitalizations after this storm. As a sub-analysis, we excluded the first 3 days after the storm in a sub-analysis, where our hypothesis there was that perhaps people who are being admitted to the hospital are being admitted for, injuries or trauma that's directly related to the storm itself, like, trauma from cutting down trees or something like that. And we considered those 2 separate exposure periods. And what we found was that hospitalizations for older adults increased significantly in the month after just this one major disaster. We found a 4% increase in 30-day all-cause hospital admissions. And when excluding those first 3 days that might have been for injuries or for admissions primarily related to injuries or trauma, we still found a 4% increase in hospitalizations. And in Alabama, where there was the bulk of the storm was the greatest number of tornadoes, greatest number of rainfall, there was almost a 10% increase in hospital admissions. So what that told us was, okay, we looked at one major storm. How about if we repeat that same analysis, but this time look at more significant and substantial hurricanes that have affected the US in recent times? And these are the 8 hurricanes we looked at over a period of about 10 years. Same data source, same type of analysis, same self-controlled case series. And what we found was that hospitalizations remained significant using this larger sample and attempting to generalize across hurricanes. So we found that hospital admission rates were 10 to 23% higher during the exposure period for each hurricane. We found, interestingly, that ICU admission rates were substantially higher depending on what the hurricane, the intensity and the location of the hurricane. And so what our study team learned from this is the implications are that there's an increase in all-cause hospitalizations, and hospitalizations specifically that we theorize are not trauma-related. This is causing excess costs for Medicare beneficiaries and the hospitals and health systems themselves, and that we need greater efforts for healthcare emergency planning. Another study that we did looked at how do disasters affect long-term survival for people with chronic conditions. And in this study, we looked at different types of cancer specifically. We used one of the best sources of cancer data out there, the Surveillance Epidemiology and Results Program, or SEER data, which is a cancer registry that is in locations across the United States. We looked specifically at Louisiana after Hurricane Katrina. In this study, we looked at 15 parishes that were and considered them our exposure population. We did a 1-to-4 match where we looked at people who were in one of those 15 parishes who had a certain type of cancer and certain socio-demographic characteristics. And we compared them to a randomly selected population from the same data set that did not, that did not experience the hurricane, but did have similar types of cancer and socio-demographic characteristics. And we did a survival analysis, finding that for people in the Katrina exposed group with certain types of cancer, specifically breast and lung cancer, they had a 15% increase in long-term mortality, 10-year mortality, compared to the unexposed group. So there was lower mortality in the group that did not experience the hurricane. So our takeaway message there are like clinical implications there, that it's not necessarily the hurricane itself that's causing this increase in mortality, long-term mortality, but rather it's the disruption in infrastructure and the disruption in access to healthcare that was associated with the cancer-related mortality. So third research study that we did was looking at health risk behaviors and how those might change after disaster exposure. Again, we looked at one of the largest sources of data about health and healthy aging out there, the Health and Retirement Study, which is conveniently located at the University of Michigan, where I am. I've been collecting data since around 1990. And we matched that participants in the Health and Retirement Study with open source FEMA data on disaster declarations. So we wanted to look at a large disaster exposed population. And what we found there was that people who had lived through a disaster had certain changes in their healthy behaviors or health risk behaviors. We found trying to move my video around so I can see where my cursor is going. So we found a change in physical activity. We found a change in weight, and less significant a change in smoking. So to use my visual abstract here, what we found is that living through a disaster can lead to less healthy behaviors among this sample of older adults. And to summarize this study a bit, we did a national longitudinal, looked at a national longitudinal cohort. So around 20,670 individuals and almost 60,000 interviews over time, used the Health and Retirement Study, and we compared people who experienced a disaster versus those who did not. So there were around 1,450 unique different disasters in the FEMA data that we used. And we found a 16% that this study population was 16% less likely to be physically active and 21% more likely to gain weight. And these were adjusted odds ratios looking at change over time in their health risk behaviors, and we adjusted for a number of different confounders. Final study I'm going to talk about, brand new study I just had come out in a couple months ago in JAMA Network Open. We looked at how mortality changed after hurricanes among older adults who are living with dementia. So we looked at 3 recent hurricanes that occurred in 2017 and 2018, fairly major catastrophic hurricanes, and looked at disaster exposed Medicare beneficiaries and then Medicare beneficiaries not exposed to disasters. What we found was that hurricane exposure was associated with increased mortality after 2 of the 3 hurricanes. Interestingly, 2 of the 2 hurricanes where mortality increased were more substantial, significant, catastrophic hurricanes. We found that mortality risk was highest in older adults. I'm sorry, the oldest old, so people who are 85 or older, and among people who are dually eligible for Medicare and Medicaid, which in this study was a proxy for poverty. So our oldest older adults and our older adults who are living with more challenging socioeconomic or economic conditions. But an interesting part of this study was that we found that mortality didn't increase substantially, or the biggest increase in mortality was around 3 to 6 months after two of the hurricanes, Hurricane Irma and Harvey. And that really made us think, like, why are we seeing this peak 3 to 6 months after the hurricane in this group of older adults who are living with dementia? When we think about dementia, we know that older adults with dementia, are almost entirely dependent on their caregivers and are lacking the situational awareness necessary to, make choices during a disaster around their health. And so depending on their caregivers. So this study formed the pilot study, formed the pilot data for a newly funded R01 equivalent called an National Institute of Health R01 equivalent called an RF1 that I'm excited to have just received notice of award on about a month ago. And so we're looking forward to digging into some of this work, looking at ways we can use data to try to prevent deaths among disaster exposed older adults who are living with dementia. So I wanted to switch to the third part of this presentation, which is talking about some of the urgent scientific and policy needs around disaster management. So I organize a lot of my thinking around the disaster management cycle of mitigation, preparedness, response, and recovery. So I think a lot about what are some of the places where we can intervene to better support populations and communities at these different phases of the disaster management cycle. So what are all the things we can do to build stronger community infrastructure as forms of mitigation? How can we prepare older adults specifically to be ready for disasters and the communities that they reside in? How can we better prepare them to be ready for these events? And then what can we do in the immediate response period? How can we apply principles of research to better support the immediate disaster response? And of course, I think about the long-term recovery of communities and how we can support communities who've had significant disasters in returning to the or in becoming more resilient to the effects of extreme weather events. But I'm also a researcher, and so I can't not think about theory. So in my thinking, I think about Bronfenbrenner's social ecological theory and how we can look at these different levels of applied to the disaster management cycle. So I'm thinking about, we're centering the individual. What is the interplay between, the interpersonal level, friends, family, neighbors, loved ones, the community, larger society itself, and views around extreme weather events, and what kind of policies we have to better support the individual, and how those all interact at the different stages of the disaster management cycle of, I say it all the time, mitigation, preparedness, response, and recovery. So for the remainder of this talk, I'm going to talk about some of those unique needs are at the individual, interpersonal, community, society, and policy levels. So to start at the individual level, a few years ago, I had the opportunity to participate in the National Poll on Healthy Aging, which is a collaboration between the University of Michigan and AARP. We did a survey module or a poll module looking at attitudes around emergency preparedness and actual actions of towards emergency preparedness that the people in the poll thought about. So around over 2,000 individuals in the poll from around age 50 to 80. We asked them things like, do you feel ready for a disaster in your community? And we also asked, if there actually was a disaster, do you have a supply of food, water, medications? Have you talked to your loved one about your evacuation planning or developed a family communication plan in the event of a disaster. And what we found was, a variety of really interesting results. We found that, most people had a 7-day supply of medication. Most people, over half, had enough food and water. So some levels of preparedness there. But we found that less than half had either signed up for emergency alerts in their community, or even knew that those sorts of emergency alerts existed. We also found that less than half, around 40%, had talked to their loved ones about what their evacuation plan might be in the event of a disaster. But kind of surprisingly, we found that most of the people in the poll, or the majority, felt like they were ready for a disaster. They knew what to do. They had supplies. They were ready. And that really, there was a disconnect there between attitudes and actual actions. Another kind of sidebar note is that we had a small sample of individuals older adults who are on devices using electricity, medically, I always say it wrong, durable medical equipment that requires electricity. So devices that they need for their health that require electricity. A small amount of people in the poll were actually using those devices, but among those people who were, we found that only around 25% actually had a backup power source or a generator. So certainly concerning findings there, although a small sample. So some of our recommendations about policy and research, and some of what we've learned, is that older adults, and not just older adults, but other groups as well, may under-prepare in general and may not be good at their own risk assessment. They think they're prepared. Their attitude is that they're prepared, but their actual actions are telling us something different. One of our strongest policy recommendations is that agencies need to be prepared to support communities throughout the disaster management cycle. So keeping in mind that although people may have these attitudes, they may not have the preparedness actions to be ready. And that's something as a community that we can do a better job of taking steps towards. And a more urgent scientific need is development of validated interventions to support preparedness. And this is an area that some of my work is emerging in, around implementation science, where we can't just tell people, like, you need to be prepared. We need to do a better job of understanding why people aren't preparing, and find interventions that can support people to want to be prepared and to take the steps to be prepared. So thinking about the interpersonal level of the social ecological model applied to disaster management, I wanted to share some qualitative data from a study I did after Hurricane Harvey, where we did qualitative interviews with home health nurses who worked through Hurricane Harvey. And I'm going to take a minute to read this because I think it's more impactful, and move all these Zoom camera pieces around. So we asked one of our participants, who was a home health nurse, about some of the challenges she faced in providing care. And her response was, I was considerably more concerned about my patients than I was my family. I knew my family was okay, but my patients were not. My son lost everything in Hurricane Harvey, but I knew that physically he was okay, and I knew we would be able to help him, and he was going to be okay. So for that reason, I didn't worry as much about my family, but my patients, I can't fix those kinds of problems for them. And maybe when I grow up, I'll get to the point where I don't feel like I should. And she went on to say, but I carried a lot of their stress. And my most memorable patient was when, and then she went on to say she had to find the patient. I did find her. I was explaining that I had been to their original residence, and she just started bawling and said that the river took it and that it was terrible. It was truly, truly terrible, because I was helpless to get her back into her home or any of those kinds of things. So I think that stress level was just tremendously high. So in thinking about, ways we can make impact on the interpersonal level, we already know from research, not mine, other research, that traumatic stress affects individuals and communities after disasters. One of my most urgent policy recommendations is that community recovery from the shock of a disaster takes years, and we need to account for this. What we don't understand on a scientific level, and where we need more research, is that understanding how traumatic stress from the disruption of a disaster manifests in adverse outcomes from chronic health conditions. We don't have that knowledge, and we need more research in that area, and also to develop interventions to better address this. Thinking about at the community level, we know that in recent years, we've seen more and more challenges with infrastructure. We're talking more and more about what is a resilient community and what is not a resilient community. I give you an example from Michigan, where I live, where in 2021, the average customer was without power more than 800 minutes over the course of the year, far higher than the US total. I'd say in my own home, in 2023, maybe from January to August, we've probably lost power for more than 24 hours, probably more than 5 times, including several days in February where we had a substantial ice storm where power was out around 5 days in February after severe ice storm, so very cold outside. We also know in Kentucky, after the July 2022 floods, that one of the challenges we saw in rural communities was a lack of forecasting, accurate forecasting. Forecasting showed an urban bias, and also a lack of broadband or internet access, so communities weren't getting the information that they needed. We talk a lot about resilient communities and what that means. I wanted to give you the definition of resilience that was adopted by the National Institute of Standards and Technology: the ability to prepare for anticipated hazards, adapt to changing conditions, withstand and recover rapidly from disruptions. Activities such as disaster preparedness, which you've heard me talk about, the disaster management cycle, are some of those key steps to resilience. There's been a lot of work around what is a resilient community. This is the infographic on my left. Is from the RAND Corporation, just one example of some of the advancements that have been made about what a resilient community looks like. There's strong relationships between organizations. Organizations are ready and prepared to respond and recover. There's enough volunteers. People can rely on each other. And individuals and families have the knowledge to prepare for and respond to a disaster. And a lot of this, these recommendations have been reflected in some of the research that I've talked about today. But another important part of disaster resilience isn't just about the community part of it or the infrastructure part of it, but there's a lot of emerging research about disaster resilience that comes from thinking about social capital or social connectedness. So how connected are we? How much trust do we have in each other? How often do we work together? Do you know your neighbor? Could you borrow a cup of sugar? Could they come to you in a disaster if they needed something? Would you check on your older adult neighbor if you knew there was a severe thunderstorm coming your way, and be a support to that person? That is what emerging research is showing is, a central aspect in disaster recovery, perhaps even more so than some of the other infrastructure related parts of disaster resilience. But resilience is really a promising concept, but it's also one of those it's been very difficult to define and measure, and led to any number of academic debate that has stymied advancements. So one of my strongest policy recommendations is that when we're thinking about resilience, we need to be thinking about making years of investments. The Rockefeller Foundation, for example, recently funded a more than $100 million project in building resilient cities. After 6 years and a change in leadership of the Rockefeller Foundation, pulled the plug essentially on the whole project years before they could actually see some of the impacts in changing larger community structures. So communities need years of support to be able to see impacts from resilience. And on a scientific or research level, we need measurement tools that can better help us to better understand what resilience is and also what it isn't in order to know what's working. So going on to policy, I wanted to talk for a minute about one of the biggest challenges in thinking about funding for disasters or disaster response, disaster management, is that we take this proactive approach to disaster management. And so in this picture, this infographic, you can see the hospital preparedness program, which is a program in the Administration for Strategic Preparedness and Response, which is part of HHS, where there's funding for the hospital preparedness program ebbs and flows with whatever the major disaster or health emergency like a pandemic is at the time. So we see these big peaks to be able to address the response to whatever the hazard or the health emergency is, and then after that we see a decline in funding. For me, I mentioned I'm a clinician with the National Disaster Medical System, which is part of HHS. We had kind of record response for our agency during COVID-19, where there were any number of us deployed multiple times, any number of new programs stood up. We're hearing now that we're in a somewhat of a funding crisis post-COVID. That funding has dried up, and now we're back to not having, as an organization, not having the training, the ability to access the kind of training that we need in order to be ready for whatever the next hazard or health emergency is that comes our way. This is one of many examples that I could give, but I think the take-home message for this slide is that we have this reactive approach rather than a proactive approach. And we need that proactive approach to better be ready for these events when they happen. But I'm getting towards the end of the talk, so I wanted to talk about some good things. So the Inflation Reduction Act of 2022 are almost $370 billion in clean energy climate investments. American families, including older adults, should see some direct benefits, particularly at the state and local level, where the idea in the Inflation Reduction Act around addressing climate impacts is that state and local governments will receive not just financial support, but also technical support. One of the biggest challenges there, though, is that communities have to be prepared to stand up fairly ambitious programs, and they may not have the capacity in their small community or even larger communities to be able to implement some of the programs that could be done with support from the Inflation Reduction Act. So really good things there in the Inflation Reduction Act in terms of addressing climate impacts. But the take-home message there is that state and local action in terms of being ready to realize the true potential of this new funding is really crucial to seeing impacts, and especially some of those long-term impacts that I mentioned, to see the benefits of thinking about resilience. So I always like to end my talk with this picture, which was taken after a hurricane in Mexico Beach, Florida. I'm from Tallahassee, Florida, which is just a couple hours away from here, and spent some of my childhood vacationing, going to the beach in Mexico Beach and nearby Port St. Joe. This was one of the only houses left standing in this neighborhood in Mexico Beach. And when reporters asked, what did you do differently? How is your house, why is your house standing with fairly minimal impact and every other house is destroyed? The homeowner said, well, I looked at the building codes, and for whatever the building codes were, I went 20% above and beyond. So I, built 20% thicker concrete poles. I used 20% stronger glass windows. And what you have here is a house that withstood a major catastrophic hurricane. So I asked the question to end this talk, what if we went 20% above and beyond for our communities and for the older adults in our communities? What might we see the health impacts, the positive health impacts in going 20% above and beyond in mitigating against the effects of a disaster? Thank you so much for having me, and I am really looking forward to any questions or conversation.
Awesome. Thank you, Suanne. That was amazing. And I invite folks to turn their cameras on if they have questions and to just jump in. I don't see any questions in the chat. I have several, but I want to open it up to the group if there are any questions. I see Jason has his camera on, but I don't know if you have a question.
Yeah, I was just going to comment relative to your last point. I know that it was just kind of a metaphor, but I think the building codes thing is actually kind of salient. So there were a lot of structures, like I saw a structure during the 2022 flood in Eastern Kentucky that got completely lifted off the foundation and moved, like a whole 2,000 square foot house. And then talking to people, it seems that there aren't even really building inspectors in some of these counties. So, there's real challenges in putting in place some of these mitigation measures. And, also, like, you made an excellent point about the Infrastructure and Jobs Act. Like, a lot of these communities aren't very well equipped to take advantage of those resources. So I thought those were excellent points.
Thanks. Yeah, I do some work. I sit on the Federal Emergency Management Agency's National Advisory Council. And in that council, we talk all the time about building codes and challenges with building codes, shortcomings there, and just sort of the inability to regulate building codes across communities. I know I talked a lot about, infrastructure, like social connectedness part of resilience, and the, infrastructure part of resilience. And I think that's what makes thinking about resilience one of these big challenges is, well, how do we talk about building codes and social connectedness in the same sentence to make advancements in a community?
Yeah, thanks, Jason. I'll jump in because I have a related question about, since you are a nurse practitioner and in the healthcare system in Kentucky, we've noticed a disconnect between emergency management and healthcare. And it seems like hospitals do their diligence and do their little drills. It's disaster preparedness month or whatever, we're going to do our drill. But then it doesn't seem that there's this connection between the healthcare system and the emergency management. So can you just talk about that? And is that true all over the country, or is this just, I don't think it's just Kentucky, but I'd love to hear you talk about that.
I definitely have thoughts about that. I identify as a health services researcher, so thinking about healthcare access and quality. And one of the projects that our team is starting to think about and do a little bit of writing about is the role of the Healthcare Coalition, which is our, like, if you're not familiar with that, they're regional based entities funded by ASPR through the Department of Health and Human Services, where their goal is to bring together the different partners in the healthcare system and healthcare setting with and include partners from emergency management and including, first response like police, fire, EMS, and some of the things that healthcare coalitions are doing are, having these community-wide drills where they're working with emergency management. They're working with, nursing homes. They're working with the main hospital in the area. But any sort of knowledge about the effectiveness of healthcare coalitions, besides that it's a good comment, a good idea, is still really lacking. So there's a lot of space there for better understanding the role of the healthcare coalition in like being a coalition and building these relationships like they're intended to do. Yeah, maybe look for a paper in a year or two from me about that. I'm not sure yet.
Yeah, that's great. I am putting this in the chat because some people know this and others don't, but I wondered if you are involved in the DR2 program at NIHS at all. And so I put the link there, the Disaster Research Response Program. Several of our members at UK Cares are involved in that. And there's been lots of work over many years. So I didn't know if you were involved in DR2 or know about it.
I know about, I have heard, I think it's Aubrey Miller.
Yeah.
I have heard him speak about it on probably 4 or 5 occasions. And, most of my support comes from the National Institute on Aging. So I haven't engaged with NIEHS as much as I'd like to, but I definitely think they're doing some amazing work, and there's a lot of cool stuff coming out of that.
Yeah, that'd be great. You could check with your MLead, the P30 Center in Michigan too, because I think they're doing some work. And I know Erin Haynes is on here and she may have ideas for you. Let me just remind you before you hop off, there is a survey link to give us feedback about today's seminar, which was excellent, Sue-Ann. What other questions? I see Robin doesn't have her audio on. I don't know if Robin's trying to ask a question. I mean, she's not mute, not that she doesn't have her audio on. Okay, maybe not. Anybody else have a question for Sue-Ann? All right, well, then I'll ask one. I have many.
Okay.
We have a couple projects in our center where we've done proof of concept using drones, working together with the USA Drone Port to use drones to deliver medical supplies, but also how to use them in a disaster and emergency response surveillance. And then this last project we funded had to do with using them to gather data in the middle of a river, for contaminants in the water. But I wondered if you have any experience or connections or projects using drones in disaster response.
I don't have experience in using drones, and I'd say that but I do know more in the humanitarian crisis space. So like in sub-Saharan Africa, for example, in conflict affected areas where there's a number of displaced people and refugees, that's where there's some real advancements coming out of. And I've found quite often in my work, there's these overlaps with humanitarian crisis and refugee settings that I can really learn from. So, so basically my knowledge about, response is coming from the humanitarian, and drones is coming from the humanitarian crisis setting. I also think, there's a number of like security concerns around the use of drones in setting up, like from a first response standpoint. And so I think there's, in the responses I've been to, I have rarely seen a drone or use of a drone or heard about it. And I'm just speaking anecdotally. And I think like, that's where those partnerships between emergency management and health and research could really be beneficial in making some advancements there.
Yeah, well, that's good. That's good feedback for us. Our UK Center for Excellence in Rural Health and has worked closely with the USA Drone Port in Hazard. And I heard you say you were in Hazard, Kentucky a few years ago. So there's a connection there. But our Community Engagement Corps is that's our region. Actually, our center serves that region. So Awesome. Any other questions anybody has? I see a few people had to hop off. Erin did say in the chat, Erin Haynes, that she would connect you with the admin for the network, for the DR2 network.
Great.
If you're interested in, and she thought it would be great if you could join. I think you'd really
Sure.
contribute highly to that group. And then I guess my last question had to do with climate and health, the relatively new strategic plan that NIH put out. I think NIA is part of it, but I know NINR is, and of course NIEHS is part of it. I wondered if you had any comments about that in terms of opportunities for more research on climate and health and disaster response research.
I'd say my first interaction with NIH was receiving a K award. And at the time, which was 2018, so not that long ago. And at the time, that was one of fairly few actively funded NIH proposals focusing on disasters. And in fact, I was told by, more senior faculty than me, like, you're never going to be able to build a funded research career studying climate change or studying disasters, even in 2018, which seems like not that long ago. So to see like the investment in the climate and health initiative is fabulous. I just hope that it's not one of those that I talked about where, it's reactive, we change administrations and that funding goes away. I'd give as an example, a challenge. HHS has their Office of Climate Change and Health Equity, which was established around 2 years ago, maybe a little more than 2 years ago. And was basically working on an unfunded mandate for the past 2 years. The upcoming budget has something like 4.65 million for this office, which, in the grand scheme of things is kind of peanuts. I'm happy that there's advancement at NIH and that there's investments across the board at NIH. I just hope that it's sustainable and growing.
Awesome. I totally agree with you there. All right. Well, any other questions you have? Anybody else? I'm so happy that you joined us today, and would love to have some follow-up conversations with you about what you're doing. And I'd love to know more about your RF1, which I'd never heard about before, and the new RO1. But
I had not heard about it until I got the notice. Yeah.
Well, congratulations.
Yeah.
That's awesome. Yeah, it's awesome. Well, good work. Good work.
Thank you.
We need more of you. We need to clone you, it sounds like, all over the place. So thanks, everyone. And we'll give you 2 minutes back. Just a reminder to please fill out your survey and give us feedback.
Thank you for having me. Bye-bye.
Welcome.